Good afternoon, and again, thank you everyone for joining us today. My name is Jessica Zavala, and I have the pleasure to welcome you on behalf of the Ohio Program for Campus Safety and Mental Health to today's webinar, Increasing Behavioral Health Access, Implementing Step Care Models to Decrease Barriers and Use Resources Effectively. Before I introduce today's presenter, I do have just a few brief announcements to share. First and foremost, CME and CEU credits are available, and the activity code for today's session is 78 LOOF. That is 78LOOF. This code will expire tomorrow, Wednesday, January 31st at 12 noon. So please be on the lookout for information posted on how to obtain credits if you are interested. Next, we invite you to join us for February's webinar on Thursday, February 29th, from 12 o'clock to 1 o'clock as we welcome Dr. Kate Atkins. She will be joining us to present on eating disorders and body positivity in college student population. So that's one you don't want to miss. And then we also hope to see you all on April 11th, right here at NeoMed for the inaugural Campus Safety and Suicide Prevention Summit. Join us for a day long of presentations, panels, and resources covering suicide prevention, postvention, advocacy, and much more. You may find additional details regarding this upcoming event and others on our website and social media channels. For today's presentation, we encourage you to post questions and comments in the Q&A or chat function. We're really excited for this to be an interactive presentation. So also, if you have questions, please feel free, to post throughout the presentation. And then finally, this webinar will be recorded and the video will be made available for viewing on our YouTube channel. And so I'm actually going to pass it over to Dr. Demers to officially kick it off and introduce himself and to provide, the best information about himself, as we know he can probably is the best person to do that. Would you say so, right?
I would hope so.
For joining us. Yes, absolutely. So without further ado, Dr. Demers.
Awesome. Thank you so much, Jessica and Chris, for having me and everyone for setting this up, making everything happen. So with that, I'm going to jump right in. I want to give one quick heads up. My 3-year-old son is at a specialist appointment, and I'm getting a couple of text updates from my partner who has him there. So if I look down to my phone a couple times, that is why. So appreciate your understanding. I'm going to be heading there right after this call. So as Jessica mentioned, we're really going to be focusing today on increasing behavioral health access and the specific way of doing so around implementing stepped care models. So with that, I want to give a little background of myself. First off, one thing I think is super important is to talk about myself as a person and how aspects of my identity have largely shaped my clinical work, if you will. So first off, as you might guess, I am the father of two little ones, 6 and 3. And for any of you who are parents on this call, parenting makes you be creative. It makes you think out of the box. You have to be silly. You have to do things differently. And that's something that is definitely carried over to my clinical work. But a couple other really important aspects of my identity that have sort of led me to where I am within the field. I'm a very passionate outdoors enthusiast, if you will. I've led backpacking trips. I've done all sorts of stuff on that front. And when you're out in the woods and a storm rolls in and you're sheltering under a kayak or whatever it might be, again, it's just another way that has really pushed me to think outside the box. I'm also a very passionate soccer player, still play, slowing down a little bit, but was lucky enough to play abroad for a short stint and win NCAAs with my college team. And again, just doing anything at an incredibly high level, in my opinion, can really shape how you think about things, your drive, how you push through things, and just overall a willingness to do things differently. And then lastly, I grew up in a multicultural household. So the maternal side of my family is from India, and my grandparents specifically came from a highly rural village in India that still to this day doesn't have running water and electricity. And being really lucky and afforded the opportunity to having visited that village throughout my childhood just exposed me to a whole new way of life. Oop, first text. We're doing good. Thanks for understanding again. Being exposed to just new ways of life, new ways of doing things, social structures, healthcare systems, and of course, mental health care supports. So jumping into myself as a professional now, I started my career actually at a therapeutic boarding school, leading backpacking trips for adolescents with severe anxiety, depression, suicidality, and substance use. And that convinced me, or however you want to put that, to say I want to get my doctorate. And that's where I went to the University of Denver to get my doctorate. And during that time, I worked with court mandated populations. I worked at an inpatient neuro and burn ICU. And then I worked in college counseling for several years. And throughout that time, I sort of always knew that's kind of where I was going to gravitate towards. So I pushed myself into other realms. But I did work at an integrated medical center on campus and wrote my dissertation on the construct of maturity. From there, again, going back to some of those aspects of my identity, I got really frustrated with, well, we're doing great things in college counseling. We also know that there are some things that, in my opinion, can be better. So I did a focus area in administration during my internship or residency year, if you will. And with that, I actually was looking for out-of-the-box postdoc experiences, and I joined the Western Interstate for Commission Higher Education Mental Health Program. It's now called the Behavioral Health Program, but our mission was to bring quality mental health services to rural and underserved areas in the Western 15 states and American territories in the Pacific. And again, grad school, in debt, not afforded the opportunity to travel. I thought I'd do it for a year because it'd be something different. And again, my territories were pretty cool with Alaska and Hawaii and some territories in the Pacific. But very quickly, I truly just developed a passion for this work. And what I realized is twofold. One is that there aren't a ton of clinicians who are working at this higher systemic, not higher, different level of care at the systemic level. And I feel really strongly that if we don't have clinicians who are implementing and pushing and advocating for change at these systemic levels, we might end up with systems of care that don't work adequately for clinicians and those seeking care. Secondly, I also just found like I had a pretty good thought process, brain, temperament, whatever it might be, to work with these large systems of care. So I fell in love with, rather than a student being my client, all of a sudden the state of Alaska was my client. So from there, I did that for a handful of years, and then I actually joined the startup world and joined an organization called U at College, making upstream mental health and well-being tools. And I actually did that for about 7 years and was lucky enough to work with about 200 campuses during that time. And most recently, coming up on 9, 10 months, I joined Mantra Health, implementing end-to-end mental health solutions. And to fully disclose, I am an employee of Mantra Health. So just to disclose that as any potential conflicts of interest, I do work for them. I am employed by them, but I hope that this will be, and my plan for this to be a very unbiased presentation. But if you do have any questions about that, please don't hesitate. So with that, I would love to learn a little bit about you all, and I just dropped in the chat a quick link. If you could either copy and paste that link into your browser, or if you have a phone handy, feel free to take a picture of the QR code in the top right-hand corner of your screen. The reason I have a US map is that I heard from organizers here that there might be some folks from outside the state, so please feel free to hopefully open that up, and we'll start seeing where people are from. I'm gonna give it a second. Normally, once they start coming in, they all kind of come in a wave. Perfect, we got one. I'm gonna be honest, I don't know my Ohio geography too well, so I can't tell you too much of where people are coming from specifically, but so far pretty Ohio heavy with a nice um, exception from Florida, so awesome. If you're joining internationally, feel free to put your pin out in the ocean somewhere and we can ask you in the chat where you're coming from. I'm gonna give it another 10 or 12 seconds to get a few more. Virginia, awesome. Very East Coast heavy, which makes sense. I actually didn't mention I live in Golden, Colorado. Oh, okay, so there we go. We're getting some more, spreading out. Awesome. Well, great representation. I'm going to jump to the next slide. So keep this screen handy. And thank you. If you can't use this software for whatever reason, please feel free to just drop any answers that we have to polls in the chat. So we're talking about mental health. How is everyone doing? I feel like we so rarely take the time to actually check in with ourselves and see how we're doing. So feel free to be honest. This is anonymous. We're not tracking your answers here. I'm hoping that we'll start getting some responses soon. There we go. Happy, overwhelmed. I can unfortunately very much relate to that experience right now. I feel like the spring semester is, in some ways a little bit lighter, but in some ways a little bit more challenging with planning for the next academic year. Confused. I hope I have not confused you right off the bat yet. Or hopefully I can undo some of that confusion. I can't see what, oh, I think that's thankful, which is awesome. I'm sure you know, but expressing gratitude can have as much positive mental health benefits as doing 15 minutes of meditation. So good. All right. So I appreciate the honesty, and I'm feeling like we have a very fair distribution of responses here. And I'm hoping, I don't know if that one was betrayed or whatever word's right above that. I never thought that these drops or pointers actually cover the words, which makes it a little difficult, but thank you for that. All right, I'm going to jump on to the next one here. What is your role on campus? Just in a word or two. This is really helpful for me just to tailor content and talking points to make sure that I'm hitting, all of the things that are most valuable to you all in the audience. So thank you for doing so. Case manager, academic and career coach, vetted clinician. I love having multidisciplinary webinars, and I hope that the questions and discussion when we get there really reflects these different perspectives. Professor, training director, awesome. Coordinator for medical student rotations, very cool. So these populate a little bit slower than I'd like sometimes, so I'm going to jump ahead. And sorry if yours did not get in here. I'm also just seeing, I think there's a couple people on the phone. I apologize that you can't participate in all this stuff, but hopefully you can check out the recording. So jumping to the next one, what's the biggest challenge that your campus faces in terms of supporting student mental health? Would love just, a word or two, a bullet, a phrase, anything would be really helpful, again, just to help me understand. Capacity, got it. That is, fortunately, unfortunately, not uncommon across the board here. We'll be getting into some of that data. Resources, I assume that's referring to resources just in terms of having the depth and diversity of resources that meet students' needs. Poverty, budget, funding and capacity, engagement. Thank you very much for all of this. Reluctance to ask for help. Thank you for bringing that one up. Lack of resources. Connecting to local resources, that can be such a challenge within our healthcare system. Lack of communication of resources, got it. Stigma. Great. Well, not great. Don't love that this is happening on all your campuses, but I appreciate your openness and transparency. And I hope that a lot of the content that we'll be covering today will provide a lot of thoughts on just ways to potentially start overcoming this. So reach financing awareness, great. Need and demand greater than providers, absolutely. So last question, this one's easy and quick. You don't have to type anything. How familiar are you with the concept of stepped care? Be honest, again, we're not tracking this. And it's very common to get all across the board. It's also okay to be unsure if you don't know what stepped care is, or you've kind of heard about it, but not quite sure. That works. Great. This is very common with the audience that we have today of folks in the helping profession. So great. So a nice distribution here. Awesome. Well, I hope that this will breed some good questions as we continue to jump in. So if you don't mind, keep that link handy because we'll come back to that. I will drop it back in the chat again when it's time, but we will be circling back to that. So before diving into some current data around mental health, just to sort of paint the picture of what we're experiencing, one thing I wanted to highlight is actually some more historical data. So this is data from 2014 from a large state institution that does a great job surveying every student who stops out early. So again, 2014, as you can say, 52 said that a major reason for them choosing to stop out was feeling emotionally depressed or distressed, 41% saying I felt socially alone, I have to move our faces here so that I can see the rest of my slide. 29% said I felt unwelcome here. So, of course, highly correlated with belongingness. And the reason I bring this up, again, I'm sure most people on this call, but not all higher ed educator administrators are familiar, was that this sort of challenge with mental health and this dramatic rise has been going on for a while. Of course, COVID has very much shined a spotlight on it, but this is not a new thing. So that was our baseline. Then COVID happens and we sort of end up here. So this is where I'll be jumping into some trends to share and paint the picture. I'm going to go through this somewhat quickly based on the roles that everyone shared. I think folks will be pretty familiar with this. So I assume, never good to assume, but being located where you are, I assume you're at least somewhat familiar with the Healthy Mind study. And if you're not, they survey students at about 500 schools nationwide. They have a huge N, and a lot of this data is from this. And a couple of things, they work really hard and do a great job getting diversity in terms of gender, ethnicity, living arrangement. And the reason I'd like to highlight all these factors is a lot of times it's very easy to say like, oh, well, that data isn't representative of my campus. If you're interested, you can actually go to the Healthy Minds website and filter this data for yourself. They make it open and accessible. If you don't know how to do that, I'm happy to point you to the right people or send you a link. But again, we have class format, the majority is in person, but we have some hybrid, online, and other, not sure what other is. And then again, a variety of actual degrees. I do think they should have thought of a different abbreviation for associate's degree, but what are you going to do? That was not my decision. And again, now turning the corner and talking a little bit more about mental health, now that we have an understanding of the demographics of that. So first off, unfortunately, we do see rates of loneliness very much persisting. So all of these, when you add them up, are ranging between 56 to 61%. And the reason I think loneliness is so important to talk about, I actually did an 18-month research process on the experience of loneliness amongst young adults and adolescents. And it's not a diagnosis in and of itself. It's not in the DSM, it's not in the ICD-10, but we all know that it is a precursor, or I don't mean to say we all know. Research has shown that it is a precursor to stress, anxiety, depression, suicidality, substance use, stop out. It's even actually correlated with a number of negative health outcomes, including increased risk for cardiovascular disease. So this is something that, again, is just sort of percolating under the surface, if you will, that is a challenge that, in my opinion, we're all grappling with. So when it comes to just some raw mental health diagnoses and numbers, this is the screening again from Healthy Minds. We see about 30% are screening positive for anxiety, 41% are screening positive for depression. And then on the other side of things, I always do want to take a moment to acknowledge that we do have a subset of students when it comes, this is measured by the flourishing scale, for those of you that are familiar. We have about 36% of students who are indeed indicating that they're flourishing, which is awesome. I don't want to forget about that. I don't want to forget about that demographic. And I do want to like put a call to action out of like, how can we do more to study these students to see what's going well, to try and scale that for other populations? So that's obviously not what this webinar is about, but I think that's something that our field as a whole can tend a little bit more attention to try and in an attempt to be more proactive than just reactive. So this is where I think some of the data gets a little bit more interesting and I can provide some insights. So again, Healthy Mind study, when we ask knowledge of campus resources, so if a student needed professional help for mental health, would they know where to turn? And overall, the numbers are good, but when we add these disagrees up together, we unfortunately see that 19% of students are saying that I would not know where to turn for help. And when I think of one in five students not knowing where to go, that is much higher than I would like, to put it bluntly. So secondly, when we ask how many students have actually reached out and gotten some sort of professional mental health support within the past year, we get 36%. So on one hand, this is an awesome stat that we are getting more students into care. We also know more students than ever are coming to campus, having already seen a therapist or having a therapist or psychiatrist, which is great. The challenge with this on the other side is we know that the very best of counseling centers in the country, I don't mean to say best, those with the largest capacity can serve between 15 and 20% of our campuses. And for those of you that are clinicians and even those of you that are tangential to it, this presents a huge challenge. So for example, when I was on campus, I had a caseload of 60 students, but I only had 20 client hours per week. When you do that quick math, that means I can definitely not do one-on-one weekly therapy, never mind biweekly therapy. And furthermore, unfortunately, what happens is you often see your higher acuity students, meaning that other students who are doing great work but might not be as acute, unfortunately, don't get seen. And I'm just noticing a question from Elizabeth. This data is actually from the 2022-2023 Healthy Minds report, which is linked down here, which you can get in the slides. So please do keep the questions coming. Do not be shy. I love being interrupted. I prefer presenting in person when we can talk, but happy to do so virtually, so don't be shy. So lastly, this is where, again, I think things get interesting. So when students are asked in the past 12 months, did you need emotional support for a mental health challenge, such as feeling sad, blue, or anxious or nervous? We unfortunately are seeing that when we add up all those that agree, we're seeing that 57% of students are agreeing with the fact that I could have used some sort of mental health support. So when we do some very simple math, we have 57 saying I could have used that support. We have 36% saying I actually sought support. We unfortunately have a delta of 21%, which again is very similar to that 19% of students who say, I don't know where I would turn if and when I needed mental health support. So here lies the challenge, in my opinion. We have so much capacity that we can't keep up, or excuse me, so much demand that we can't keep up. Yet we also have students whose needs are not being met. The idea of being able to address both those, of course, is extremely challenging. And this is where stepped care models can play a very unique role. Sorry, just getting a quick test from my partner. They're optimistic about things. We have to go back in a week. Great news. Thank you very much. I should be good with texts now. So the last thing I do want to mention before we sort of talk about macro trends and where to go specifically in terms of stepped care, one thing I do think is incredibly important in all of this work is making sure that we dive a little bit deeper into see where our service gaps specifically for students from historically marginalized communities. So this again, Healthy Minds report, when we ask students, have you reached out or gone to any therapy defined as professional mental health care? What's really nice is we do see that there are no like major gaps, if you will. But when we look at this range, we are seeing it range from 21 to 34%. So I always encourage folks that if we are seeing underrepresentation for specific groups on campus, we have to understand what's getting in the way. And something that I always say is one size often fits none. And if we try and do something that might not intentionally, of course, be marketed or geared towards majority populations, if we're not making sure that these are reaching other groups, we might accidentally be exacerbating some of these gaps that exist. And of course, this is exacerbated by personal stigma by race, of course, stigma related to mental health. So this, not surprisingly, somewhat mirrors the last chart in reverse when it comes to actual utilization. So as we see, again, from the Healthy Minds study, we see that Asian American students are saying that they are experiencing the higher level of perceived stigma. Seeing a quick question coming in, is this survey geared towards freshman students or all populations? Great question. It is geared towards all populations. I did not provide a breakdown of year in school, but I could get that for you. I don't know the distribution off the top of my head, but again, it is geared towards recruiting students from their entire student experience. It does include grad students as well. So thanks for that question and happy to follow up with that. So the last thing I want to mention before turning the quarter is really acknowledging that basic needs and mental health, in my opinion, are very much intertwined. So from the Real College survey, which you might be familiar with, as it is sort of in your neck of the woods, they interview or get data from 500 institutions with the primary goal of providing institutions the ability to support students with basic needs. And in 2020, they actually found that 58% of respondents had some type of basic needs insecurity, the most common one being not having enough funds to be able to pay rent or utilities, and 38% reported experiencing food insecurity in the last 30 days. So the reason I bring this up is if a student is coping with basic needs, we need to make sure we address basic human needs before we can work on connecting students to higher levels of care. So this is incredibly important in this work, and I do think that these two worlds very much need to be intertwined to lead to successful health outcomes. So I presented a lot of data. I'm going to try and sum it up really quickly for us all. So again, Healthy Minds, National Education Association, we know that currently 60% of college students meet criteria for at least one mental health condition, which is a drastic increase in the past decade. We also know that 81% of students are endorsing that their mental health has negatively impacted their academic performance in the past 4 weeks. The reason that's so significant, in my opinion, or not significant, but is an important driver of change, is, in my opinion, we've been sounding this alarm bell for mental health for the last decade. But now, since we're seeing more of a non-existent line from mental health to student success, persistence, and retention, sort of turn into a dotted line, let's say in 2017 through 2020, and now that really becoming much more of like a real line, if you will. There is some data that is very directly indicating that students with mental health challenges that go untreated are less likely to be retained. What's good about that is schools are looking at mental health as a much more holistic challenge to be addressed. It's not and can't just be the job of the counseling center, which in my opinion has really opened up the ability for campuses to start implementing much bigger systemic interventions like stepped care. Getting a little ahead of myself, but you know where we're going anyway based on the title. So the other thing I do want to highlight is the college landscape is challenging for a number of reasons. So this is a real Google search I did just recently. If you want to do it, feel free to do it. Go to Google and type in college makes me feel. And then that suggestive search, unfortunately, is throwing out a bunch of things that students are searching for, which as you can see from your screen is not an awesome picture. And why I bring this up is one, we know students are having a challenging time, but we also know that helpers and supporters on campus are also having difficult times because we have our own challenges and we're trying to support a group of individuals who are having a tough time. And again, when we jump into the percentage, this is from Gallup, I believe. Yep, Gallup down here. The percent of bachelor students citing emotional stress as a reason they considered stopping their coursework, 42% in 2020, 76 in 2021. We see a slight decline in 2022. I'm very interested to see what comes about in 2023. But again, the vast majority of students are saying that mental health is getting in the way of their academic performance. So we have this bubble, things are going in this direction, and then COVID happens. And what goes along with that is, on one hand, an awesome injection of dollars, of VC funding, of folks getting into the behavioral health technology space. Again, on one hand, that is awesome in that we are increasing the diversity of options, the accessibility, we're having more scalable tools. But as you know, on the other hand, there's a reality that there's no licensing board for digital interventions across the board. There's a lot of questions about what's good, what's not. How do you all do your jobs that you have that you're already bursting at the seams and having difficulty keeping up, then also do all this vetting of these digital health tools on campus? So in my opinion, it's presented a lot of challenges for campuses. And again, the higher education scene has not been untouched from this. When you walk into an exhibit hall nowadays, it looks so different than it did back in, 2010, never mind 2015, or other way around, 2015 to 2020. There is a vast array of vendors in the space, which again can be a full-time job and is, but only in a very small subset of campuses who actually just have someone looking at all the tools out there to see what might fit within campus ecosystems. So going back to that poll, I'm going to drop it back in the chat. I would love to hear, does your campus utilize any form of digital health, mental health, or wellness tool? Again, really, really big bucket, just anything. Always challenging when it's 100% because I don't know if more than one person responded or if a lot have. I'm hoping a lot have, and the answer might just be overwhelmingly yes. So I'm going to give it another quick second here. All right, we got at least a few people coming in, and looking at the math behind those numbers, I think we're doing all right. And totally fine to be unsure. Not everyone is a clinician on campus that would be informed about this data. All right, so the vast majority, we're going to go with a yes. Follow-up question. When my slides decide to advance, work with me here. So if yes, and you're familiar with it, how would you rate the adoption and utilization of that service or group of services? I'm always very interested in this question. Awesome. And I'm glad we have some people responding. So perfect. Well, I'm glad to see we have some very goods. And what I generally see is unfortunately respondents sort of gravitating more towards the lower half here in sort of the poor and neutral. So I'm really actually pleased to see we have a decent percentage, let's say almost 40% saying that it's good or very good. So that is awesome. What you're doing, keep doing it, brag about it, talk to more people, write some blogs, speak at conferences. And if you're open, I'd be very interested in connecting just to hear what's working for you. So that's great. But I am seeing on the other side that there is a large population who's saying it's not quite where we want it to be. And I do often, when presenting, see a lot of neutrals. So thank you so much for your participation there. So this is really helpful. So again, working with about 200 campuses, doing a lot of speaking, consulting, advising for campuses, what I've sort of seen is we have this bubble of mental health coming up. We have all these solutions on campus. In COVID, a lot of campuses had to react very quickly and pulled a bunch of services together to, again, meet students' need while they are being served virtually. And what I found is oftentimes campuses aren't marketing machines. What I mean by that is, there's an upstream mental health and well-being tool, there's a crisis line, there's a counseling center that's doing wellness workshops and all sorts of different supports, but students just don't know about it. And one stat that I didn't include in the presentation, but the reality is we see about 50% of students who are stopping out due to a mental health condition actually having never utilized resources on campus for that condition. So we hear this over and over again that, the services are there, but for some reason we're just not able to integrate them. Secondly, on the other side, and in my experience, this is a bit of the minority of campuses that experience this, is if and when you do market it great, students are out there, the reality is that campuses are resource-rich environments. And oftentimes, if I'm a student who's anxious, depressed, stressed, whatever it might be, if I have 4 service offerings and I can't decide whether to do therapy, ECBT, see a telehealth provider, call a crisis line, or go to the counseling center, that might overwhelm me. I might experience some decision paralysis and not make a decision. Where I see this coming to life more often than not is with faculty and staff or academic advising. So those folks are oftentimes individuals who see students one-on-one semester over semester. They're often the first individuals to see mental health within a student getting in the way of their performance. And with that, if there's 6 different tools that I have to be aware of, I don't feel comfortable with the talk tracks for each or don't feel comfortable referring students to option A versus option B, option C, I'm unfortunately just not going to make that referral, which again is not something we want. So I'm seeing a comment come in. In my opinion, students are not willing to go to campus resources because they fear it might not be confidential. Elizabeth, I completely agree with you. While stigma's very much going down, we do see some students who are much more comfortable reaching out for support. There is absolutely a subset who does not. I've seen this particularly prevalent for some groups, students from historically marginalized communities, and then graduate students, especially in the health sciences. For all the reasons you can imagine, we can do a whole nother webinar on that, but I do think that that's very important. And I can share within our telehealth services, we actually serve about 35% of students in our care identify as sexual minorities. And the reason I bring that up in my hypothesis, we have some data to support this, is that a lot of students who, again, have been historically marginalized don't feel comfortable going to the counseling center, waiting in the waiting room, et cetera, et cetera. So I think it's the last poll, but if you have this link handy, would love to know, do these scenarios resonate with the student experience on your campus? Does it feel like you more fall towards that lack of awareness side, that decision paralysis, a little bit of both, or neither? All right, nice distribution. In my experience, I've seen that most people that I presented with in the last, let's say, 6 months fall more in this lack of awareness bucket, which is what folks are gravitating towards. And we have both, neither. Great. Okay, so this is right where I'd sort of guess where folks would respond. And with that, I'm excited to sort of turn the corner and talk a little bit more about stepped care. I don't know why these make me click 3 or 4 times before moving on. So again, we talked about the data, we talked about the challenge. I'm not glad it resonates, but I'm glad that we at least have a solution that is matching your experience. And one thing I firmly believe is that stepped care models are something that I'm not going to pretend that this is a magic bullet, but I think it is something that can very significantly alleviate a lot of these challenges. And I do also very firmly believe that within 5 to 10 years, the majority of campuses are going to have some sort of stepped care model implemented, whether they're developing it in-house, working with outside providers, or a combination of the two. I do think stepped care models are going to be a very prevalent piece of a student mental health care experience on campus. I also do think that in our healthcare system at large. So, what the heck is a stepped care model? I don't like reading slides, but I am going to read this one definition because I want to get it right. So, stepped care is a system of delivering and monitoring mental health treatment. So, the most effective yet resource intensive treatment is delivered first. I think I forgot the word least in there. That is a very important word. Yet, least resource intensive treatment is delivered first. Why that's so important is we know that we have a capacity issue right now. We have a mental health shortage, a provider shortage right now. That's very significant in rural areas, still in urban areas. We have access issues, everything in between. Our healthcare system has some challenges. Whole nother rant and soapbox for another day. But stepped care has a unique ability to be able to serve more individuals because what we're not doing is just saying anyone who's in tiers on campus should go to individual therapy. I'm so passionate about this because oftentimes, and again, when I was working on campus, anytime a faculty member, a supporter on campus saw a student having a challenge, they said, let's go right to counseling. When again, if that student didn't know where they were going to sleep tonight, just failed a test, were worried about losing a scholarship, mental health is likely a supportive service for that student, but maybe not the first stop. Secondly, the other thing that our traditional model of care, where we push a lot of students to therapy, where that's sort of led us, is we're not doing enough, in my opinion, of this preventative work. Stepped care models really allow us to do a lot more prevention, resilience building, coping strategies training, so that ideally students don't end up needing subsequent care. But the other piece that's important about a stepped care model, two things I'll mention. One is that once a student's in the system, they can very easily be escalated or de-escalated to a different level of care. So again, let's say I'm a student, going back to Elizabeth's comment, who didn't feel willing to go to a campus resource because therapy feels a little bit too close or not confidential. Maybe I'm okay going to an off-campus support or seeing a peer coach because that feels more approachable. If and when some more significant mental health and clinical issues are surfaced, it has to be very easy to refer that student up to therapy or an appropriate level of care. And within this model, once a peer, for example, has a relationship, that peer might actually be able to help overcome that stigma and reduce those barriers. The last thing I want to mention is there's no perfect stepped care model. I think there's some important buckets that make a cohesive and thought through stepped care model. But something that's important is you have to know your campus and what the needs are of your specific student body. So what I'm presenting today is, again, what we've developed, what has been implemented on some campuses, but it's not the only way to do it. So I want to dive into a stepped care model again that we've implemented and had some success with, and I'll actually be able to share it in a case study format just to associate some outcomes. But very quickly, I want to highlight these three main buckets and talk about the services within each and why, in my opinion, they work. So promotion, prevention, intervention. Again, knowing you all, I think you're familiar with those buckets. But the first level, going in promotion, again, are activities that are really designed to help increase resilience and coping strategies to prevent downstream challenges. So we have developed a, ugh, a lot, I forget, it's 64 or something, self-care modules that are rooted in DBT. So these are evidence-based modules that are 5 to 8 minutes that, again, students can engage in. They can be embedded as part of orientation and first-year seminars, whatever it might be. But the key aspect here, whatever you're doing, is integrating some activities that can promote resilience into upstream services and ideally get the vast majority of students utilizing them. Another thing we have here is a peer support community. This is actually through Togetherall, which some of you might be familiar with, and they are world, countries. They're huge, and they are anonymous peer-to-peer support, but what's unique is it is clinically moderated. So one thing you're going to hear me say over and over again through all these things, when you're making a stepped care model, be very mindful of making sure that it is evidence-based, that you're getting reporting back, that you can make informed decision based on what you're providing your students. So that's a very important piece of things. Jumping up to the next level of care is prevention. So, a couple of services that I think are really important in this realm. One is what we call on demand emotional support. So, many campuses have what's called like a Let's Talk program or something like that. So, to give a quick example, say I'm a student, I just failed the test, worried about losing my scholarship, shame and stigma about telling my parents I'm really, really worked up right now in the moment. I'm not about to hurt myself or someone else, so I don't feel the need to call a 24/7 crisis line. But on the other hand, I don't want to wait 2 or 3 days, or sometimes a week or two, for an intake appointment. So, what this service does, and again, Let's Talk programs often do it or drop in hours, they allow students to connect with a clinician quickly or much more quickly. In our service, about 10 minutes. And what that does is give students the ability to engage in some problem solving right then and there to help them solve whatever challenge might be. And of course, if that turns into a crisis appointment, that's okay. We connected with a student we might not have otherwise. But the vast majority of times for students, again, with that example of failing a test, doing some solution focused work right then and there in the moment with a clinician can have tremendous impacts on preventing downstream clinical presentations. So I'm going to go through the rest pretty quickly. Care navigation and triage, in my opinion, are very helpful. A lot of times students don't know where to start. They want to talk to someone. On many campuses, this looks like case management. For us, we call it care navigation, but the ability to be able to connect and say, this is what I'm experiencing, and then have a care navigator make a recommendation, whether that be connecting them with self-care because they're maybe experiencing some subclinical issues or emotional wellness coaching, or of course, connecting them very quickly to clinical care. Another piece of stepped care models, which in my opinion are gaining a lot more traction, is emotional wellness coaching. Whether this is through peer educators, licensed coaches, um, why I'm so passionate about this is when we look at the research, about 30% of students in clinical care actually have subclinical challenges and could be equally seen as well, in my experience, maybe even better with an emotional wellness coach. If I'm homesick, if I'm having difficulty with time management, if I haven't kind of plugged in socially, these are all things that an emotional wellness coach can do incredibly well with students, being a little bit more directive, providing that increased accountability, potentially doing asynchronous messaging to help students in a way that, again, clinicians can't and in my opinion shouldn't. So I'm not going to spend too much time here. Clinical care is essential. Whatever you have on campus, or if you choose to work with a third-party provider, ask all the right questions, understand their clinical protocols, understand session limits, crisis protocols, and everything in between. But one thing that I will share that I'm very excited about is we recently launched a partnership with Charlie Health, which is a virtual intensive outpatient provider program, which you can look into and look into partnering on your own should you be interested. Why I think this is so important is that oftentimes we have students on campus whose needs are greater than can be met in one-on-one therapy in a counseling center or in our instance, telehealth. With that, historically, what students are sort of forced to do if they do need an intensive outpatient program, and for those of you that aren't familiar, intensive outpatient programs are therapeutic interventions that are actually between 8 and 10 hours a week. They consist of group, family work, medication management, one-on-one therapy, and they have great outcomes, but as you can tell, they're a huge time commitment. So if I'm a student, I'm fully enrolled on campus, I identify that, I need an IOP program, I oftentimes actually have to stop out and relocate somewhere else, especially if I'm in a rural area, because the likelihood of an IOP program being in my community is very low. So what this offers students the ability to do is do so virtually. The clinical outcomes are very high and equivalent to many IOP programs. And what it allows students to do is potentially take a reduced course load rather than stopping out completely, which is a huge win because we know, unfortunately, from research that when students do stop out, more often than not, they don't come back. So thinking about how you're treating and working with students and supporting students with severe and persistent mental illness, I think is something really important when it comes to the stepped care model. And then lastly, crisis care, in my opinion, is pretty self-explanatory. So no worries there. So in addition to making this model, so let's say you do all the work, you have a great stepped care model, what's really important is that students feel like there's no wrong door. Whether they go to the counseling center, whether they're referred to by a faculty or staff member, they find whatever tool it might be, on their own. It has to be really easy. And one of my soapboxes nowadays is if we're saying that mental health and well-being is just as important as academics, we need to feature mental health services in those high visibility places that students are going every day that house their academic coursework. So LMS is short for Learning Management Systems, and research actually shows that about 94% of students are in the learning management system at least 3 times per week. So when I've worked with campuses and we're successfully able to embed some mental health supports, even as simple as a link within the learning management system, we see utilization go up dramatically. And what's nice about that, again, I know we have capacity issues, so don't worry too much. We're getting students who are earlier on in their mental health care journey because again, we're taking a population health approach and being proactive rather than waiting until a student's flunking out or is referred by an RA because they're engaging in cutting behavior. And again, when it comes to stepped care and we're using this population approach, we connect students with some sort of case management or care coordination. Then we can make sure the right percentage of students are getting self-care, the right percentage of students are going to therapy, psychiatry, and specialty care, rather than bottlenecking everyone over to therapeutic intakes. So in the interest of time, I'm going to jump ahead and skip that slide. That's why I went really quickly. The other thing that stepped care offers, and this is huge in my opinion, is a singular reporting dashboard or singular reporting place. So right now, going back to that scenario where a campus has an upstream wellness tool, which is awesome and great to have, maybe a crisis service, a telehealth provider, and then the counseling center. Those are 4 different data sources that you then have to pull together, ideally have the same timeline, similar metrics, and be able to understand what students are going to, when, what referrals were appropriate, what weren't. And a singular stepped care model lets you have one place that you can look at multiple interventions. And you can really start to tweak and understand, wow, we're sending way too many students to therapy, for example. Let's make sure that our care navigators or our screening tools are tweaked accordingly to be able to route students to appropriate levels of care. Something else that's really important here, going back to that those diversity slides that I shared earlier on, is it can also make sure that we are serving students from historically marginalized communities. If, for example, I go in the dashboard and I'm working with the campus and I see that we're seeing underrepresentation from a specific group, let's say Asian Americans within therapy or our emotional wellness coaching, what I can do is very quickly say something is missing the mark in terms of our messaging or our outreach, whatever it might be. We need to tweak that to make sure, again, that we're not exacerbating some um, gaps that exist on campus. So this is just an example of, an entry point analysis that you can do to say all the users who enter a stepped care model. In our instance, we have about 83% of students actually completing, we call it a level of care assessment. And then we can see what percentage of students are getting referred to each. And we've been getting better and better with time, which is awesome. And this last month, we actually had 0% of students who started either coaching or therapy and had to be referred to a different service. So again, a singular stepped care model with a singular point of entry can really help you get students to the right level of care. And I just wanted to show, this is from a presentation I did at NASPA WRC this past fall with a close friend, Leah Jernigan, and the VP of Student Affairs at Eastern Washington University, and this is how they organize their stepped care guide. The reason I bring this up is it is likely that you have a number of pieces of a stepped care model already embedded in your campus. They might just be discrepant. And obviously it takes time and thought and some strategy and advocating for resources. But as you can start pulling these things together, you can all of a sudden create a much more cohesive experience for students. And rather than starting from scratch, you might notice like, wow, I actually already have 5 pieces of a stepped care model on my campus. I really only need to add X, Y, or Z, which can be much less daunting of a task and much less resource intensive than saying, I'm building from the bottom up. And I'd also say the reason you shouldn't just break everything down and build from the bottom up is my guess is you have a lot of great resources on campus and people that are very invested in them that you should be leaning into and working with rather than against. So the last piece I want to share when it comes to campus or implementing a stepped care model is that you can't just make a stepped care model and say, great, we're done. You have to make sure that you are doing the work to get it in the hands of students, to embed it across departmentally, to make sure that faculty and staff are aware of the services being offered. So there's ways to work cross-departmentally to embed things into orientation, work with academic advisors, faculty and staff, res life, learning management system, as I mentioned. But most importantly, one thing another soapbox I have, alluded to so many soapboxes, as a helper, being in the helping profession, I have a acute desire, as do many education professionals, to present to students, to go and present in first year seminar in a class to table, which is awesome. And there is a huge place for that. And I want to advocate to keep doing that. But I also want to highlight that let's say it took me an hour to present to a class. Maybe I do a great presentation, but the majority of students don't need mental health supports that day, so they forget about it when they need it 3 months later. If I put that same hour of time into advocating and working with leaders of my website on campus and get a link in the learning management system or a link on syllabi, for example, that is going to work for me 24/7, 365 every day of the year. So make sure that you are thinking, in addition to the in-person activities, about evergreen ways that you can put a little bit of time in that are going to pay dividends later. And the last thing I'd like to share, when we work with campuses and we're able to integrate these, again, at a much higher level than just in the counseling center, we've been able to see overrepresentation within our clinical care from students who identify as being from marginalized populations. So again, we see overrepresentation of individuals who identify as Hispanic, 5%, Asian American, 3%, and all of that. So this work can pay off. I'm going to be really quickly and fly through outcomes because I want to make sure we have some time for questions. The reason I'm specifically calling out a couple of these interventions within stepped care is that these are a little bit newer, if you will. So when it comes to coaching outcomes, again, if we can get the right students into coaching programs, in my opinion and in my experience, we can have some great outcomes. I think these really speak for themselves. I'm not going to dive into them, but they're really good mental health outcomes. And again, very much associated with decreasing risk for stopping out. When it comes to that on-demand emotional support, in the interest of time, I'm just going to highlight these two stats. We see that students are self-reporting a 30% reduction in stress when they're able to be seen, again, when they're actually experiencing that crisis, which is huge. More importantly, not more importantly, also importantly, we see 60% of students who use this on-demand emotional support saying, I don't know what I would have done if I didn't have this support, or I wouldn't have reached out for support. Why that's so important is that's likely a student who might get escalated and present to our systems later down the road. I'm going to skip this slide and just jump to mental health outcomes. So within our model, we've seen a 67% of students improving in anxiety, 68, anxiety, 68 with depression, 33% improving on the flourishing scale. And a very important one, in my opinion, especially for advocating for resources, is we see 82% of students with severe depression significantly improving. Why I think that's so important is that is, of course, a group of students who are experiencing significant clinical symptoms are the most likely to have an emergency, as well as the most likely to stop out. I'm going to skip that slide and jump right to take homes. If you do have questions, if you want to start typing them in, because I know I'm coming right up to time, I'm very sorry I didn't give you a few more minutes, but please feel free to do so. So when it comes to take homes, a couple really quickly. One, we know that mental health is getting in the way of persistence, and we have to embed these services within student success initiatives. We need academic advisors and other folks on campus helping us refer students to care. Two stepped care models can be a great scalable solution. Again, not a magic bullet, but to help get students to the right level of care at the right time. And third, building this model isn't enough. We have to make sure that it's meeting students on their terms, that we have holistic buy-in across campus, it's integrated into places and things that students are using every day, and that you're always getting reporting so that you can be tweaking and making things better. That was quicker than I wanted to do it, but I want to give some time for questions and also kick it back to Jessica for any last minute thoughts. But thank you so much for joining. I am happy to stick around for a little bit and answer any questions.
And thank you so much. And I think you all could certainly join me in appreciating the wealth of information that was provided by Dr. Demers today on the STEP care model. And so I do know we do have, looks like a couple of this questions that has been presented. And I also want to just address one and share that, yes, the slides will be disseminated in the event that you did not see that in the chat function. And thank you also for sharing your contact information, as we are very close on time. But there's a question regarding at what point is the screening administered. So if you could speak to that just for a little bit.
I'm more than happy to. So again, I'll speak to how our model works, but there are multiple ways to do so. So the way we've approached it is students, when they onboard, they take that level of care assessment, if you will, to get placed in the right level of care. And then for folks who do get into our clinical care, we actually administer the PHQ 8, GAD 7, and a few other questions at the start of each therapy session, as well as discharge. So again, no perfect way to do it, whatever works for you, but I personally like being very data driven. So Elizabeth, Jessica, I'm just going to read questions and answer them if that's okay with you. Regarding the link in the LMS, does it only have to be university resources available that way? Or can there be links to outside resources in the LMS? That may be different for each school, but I'm curious. Great question. So say 5 to 10 years ago, when I talked to LMS administrators on campus, they would say, if it doesn't have to do with mental health, it's not getting in my LMS, which was a huge bummer. I have, thankfully, because of the trends that I presented today, been seeing a much more willingness, if you will, across campuses. So I do think it's going to be unique to your school, but if I was in your shoes and going to advocate the why, I would say, here's the resource, here's the why. And if you're familiar with the Healthy Minds Return on Investment calculator, it is a great tool to be able to actually show how many students you might retain from a specific intervention. I'm happy to follow up via email if you're not familiar with that, but I've seen that work in a number of instances that can win over some administrators.
Well, we are right at time. And again, thank you so much, Dr. Demers, for that wonderful presentation on the STEP care model, and certainly reminding us about promotion, prevention, and intervention, and certainly the outcomes, and sharing all of that information. One last time, if you are interested in CEUs for today, the code is 78LOOF. That is 78LOOF. And we hope to see you back next month on February 29th at 12 noon for a presentation on eating disorders and body positivity in college student populations, as well as here on April 11th at NeoMed for the inaugural Campus Safety and Suicide Prevention Summit. So thank you all again, and have a wonderful afternoon. Thank you.
Thanks, everyone.